go on to Dr. Shantan and unmute yourself, Dr. Shantan. And then what he is going to tell us about, many a time, most of the times, the cirrhosis of liver is seen incidentally. When somebody goes for an endoscopy, there are varices are there. When goes for an ultrasound, there is a cirrhosis of liver is there. So how best we can first confirm a suspected early cirrhosis? That's what Dr. Shantan is going to tell us. Please go ahead, Dr. Shantan. Your slides are seen.
Okay, sir.
And you are audible. Go ahead.
Okay, sir. At the outset, I would like to thank IMA team members along with Dr. P. N. Rao sir to give this opportunity. So now the topic of discussion will be how to confirm suspected early cirrhosis. So coming to the slogan, currently one life, one liver. There's only one life and we have only one liver. Save your liver and save your life. So in brief, I want to just highlight the importance of this detection of early cirrhosis in form of a short diagram. This is a tip of an iceberg where patients will be diagnosed and symptomatic, where some of the patients are diagnosed and asymptomatic, but the majority of the patients are undiagnosed. So this undiagnosed patients group, which are at most important for early detection to prevent the progression of the disease. So the outline of my talk will be based upon the following topics. So just as what is the difference between the normal liver and the cirrhotic liver? The normal liver shows no signs of scarring, and on the other side in the cirrhosis, the scar tissue replaces the whole of the normal liver tissue. There's a huge burden of cirrhosis, especially also present in India, where almost there are 20 to 30 deaths per 1 lakh. This is as per the latest guidelines which are there, which have been published. So coming to the etiology of cirrhosis, what factors and what are the causes which leads to the development of cirrhosis? Specifically mentioning the viral causes, the hepatitis B and C, the non-alcoholic steatohepatitis, as previously mentioned by Dr. Anand, which has been in detail, which is coming the leading cause of cirrhosis currently. There are other autoimmune diseases such as autoimmune hepatitis, primary sclerosing cholangitis, other chronic primary biliary cirrhosis, all leads to cirrhosis. Also, on the other end, from pediatrics to the adulthood, there could be features of hemochromatosis and Wilson's disease, which leads to cirrhosis. So, coming to the stages of liver disease, in healthy liver, where some amount of fat deposition or some amount of inflammation leads to hepatic fibrosis. This hepatic fibrosis and healthy liver are interchangeable, and the patient can go back to the normal state with current precautions along with current treatment. But once the hepatic cirrhosis leads to cirrhosis, the hepatic fibrosis leads to cirrhosis, there's severe scarring in the liver, it disturbs the liver function, and it's a one-way phenomenon. From the cirrhosis, many patients won't come back to the normal state, and this state of cirrhosis also leads to formation of cancers within the liver. Clinically, how does this show up? The clinical progression of liver disease, where in the pre-cirrhotic stage, where there is no fibrosis and the liver pressures are within the normal range. However, once the cirrhotic sets in, there is scars and fibrous tissues within the liver, and this leads to an increase in the hepatic venous pressure gradient, which is the portal pressure, which has been indirect evidence of portal pressure. And once increase in portal pressures, there are other clinical signs which show up. However, from this stage, going to this stage, which is a decompensated stage, where the patient has lost the complete capacity of liver regeneration, and along with patient decompensate with the formation of ascites, varicose hemorrhage, and other complications leading to renal failure, jaundice, encephalopathy. And this is a stage where we need to act upon for early detection and prevent the progression, even if the patient is in early cirrhosis, and prevent the progression to the decompensated state, which is the later stage. Left untreated, this early cirrhosis will progress into the advanced stage, with leading to further complications, reducing the quality of life, and later on leading to death. So this is where we act upon from preventing the progression of this disease. How to prevent the progression? One is the early detection, the staging of disease, the removal or treatment of the etiological factors, diet, exercise, physical rehabilitation, and the vaccinations to prevent recurrent infection. So when to suspect liver disease or when to suspect early cirrhosis? The common signs which the patient present with. One is the weight loss. Patient might present only with the persistent weight loss. The other major common complaints which the patient come up to the OPD is the pain in the right hypochondrium or the discomfort in the right hypochondrium. Patient might be having persistent nausea or vomiting. Patient might be having in patients with viral hepatitis, on patient with alcoholic hepatitis, patient can come with yellowish discoloration of skin and sclera. Patient come with dark urine. and some patients might present with epistaxis. Also, the one more major symptom which the patient presents is a fatigue and loss of appetite. Majority of the patients in the early stage come with only complaint of fatigue, loss of appetite, nausea, abdominal bloating. Also, when seen in few the clinical detailly, the patient you also can see the swelling of feet, ankles, and legs in terms of pedal edema, and there are other signs which can be examined for detection of cirrhosis. The clinical signs, how to suspect early liver cirrhosis. One is the hepatomegaly, and along with a firm liver on the examination, there will be patient with splenomegaly, with enlarged spleen. On correct examination, we can appreciate the splenomegaly. In some patients, there will be hypoalbuminemia, severe hypoalbuminemia leading to leukonychia. These are patients which present with cirrhosis. Increased bilirubin, which are icteric, which can be seen on clinical examination. This is a spider angiometer, which is mostly seen in patients with alcoholic liver disease because of the hyperesteranism previously shown by Dr. Anand. Patient will present with in the SVC territory. Unexplained coagulation abnormality and unexplained bruises, which are seen all over any part of the body. The other thing is a pedal edema, which can be appreciated in the patient might present with only pedal edema as a complaint. On the advanced stage, where we can see also the Dupuytren's contracture, comparing the two patients where the Dupuytren contracture, and along with a subtle sign of thenar atrophy or the small muscle wasting also can be seen appreciated in patients with liver cirrhosis. One more common sign is a fetal hepaticus. So whenever a patient comes saying that he has all offensive smell breath, so we have to be worried about and we have to be worked up for liver cirrhosis. So what are the tests to confirm the cirrhosis? There are two types. So what is the invasive test and the non-invasive test? The invasive test is a liver biopsy, which is a gold standard, and there are other non-invasive tests. What is the problem with the biopsy? Even though it is a gold standard, it is an invasive procedure needing hospitalization. It requires expertise to perform the biopsy, carries a definite risk of serious complications such as bleeding. Patients are unwilling to undergo the procedure because it's invasive. There's large amount of sampling error might be there if the sample is not picked up properly. There is inter-observer variation between the pathologists. Repeated measurements are difficult, and hence a need of simpler, non-invasive, observed independent and repeatable tests are needed in place of the biopsy. So the further non-invasive assessment, there are indirect tests, the imaging and the specialized tests. The indirect test, mainly the hemogram, especially we need to look at the platelet count. Thrombocytopenia is one of the important feature and is a starting feature where patient might be progressing to cirrhosis or is already cirrhotic. So keep a watch on the platelet count. The biochemical test, the ALT, AST, and the albumin. So the albumin being the synthetic function of the liver, in patients with cirrhosis, you find a low albumin. Also the composite scores, which I'll be mentioning later, which is the FIB4, APRI, and the fibro test, are useful in assessment of early cirrhosis. Imaging, the ultrasound, CT, MRI, and there are specialized tests such as endoscopy and elastography. So what are the advantages of these non-invasive tests? First, it is easy to perform. It is free from complications. There's widespread availability. It can be done in an outpatient setting. It's a bedside test also. They are cheap, do not require any specialized training. And there's always a homogeneity in this test because there are automatic measurements of their component variables are there. There's a lot of homogeneity among all the tests. And along with, there are few tools for automated computation of score currently available, such as apps, which can be done on bedside and OPD-based clinic, and easy to repeat at frequent intervals, and can also compare with the changes in the treatment and the changes in the diet and exercise. We can compare the amount of fibrosis and change in the scores also. So coming to the first non-invasive, which is the USG ultrasound abdomen. So ultrasound abdomen, on ultrasound, the things which we need to look at is one is a small or any shrunken liver, the nodular surface with any irregular margins. There's enlarged caudate lobe or volume distribution, which is there on ultrasound. There's coarse echotexture of the liver. Also, along with the identification of cirrhosis, we need to see the features of any portal hypertension, such as the enlarged spleen. There's dilated portal vein, a diameter of greater than 12 mm is significant of dilated portal vein, and presence of a venous collaterals. Also, the complications associated with the cirrhosis, such as the ascites, can be seen in the ultrasound. So in this ultrasound, which we see the normal liver and the cirrhotic liver, where it is irregular, the nodular and shrunken liver. Also, in this patient, which is a low probe frequency probe, where we can see the surface of the liver is irregular and nodular when compared to the normal surface of the liver, which is smooth. Also, the caudate lobe in this picture, which can be seen in the patients with cirrhosis, there's hypertrophy of the caudate lobe. Also, the flow, the portal flow, which is important in patients with normal patients, there will be normal forward flow in the portal vein, whereas in the patient with cirrhosis, there is this in advanced stage where you can see a centrifugal flow, this abnormal reverse flow, which we can see in the portal vein. The other commonly used non-invasive tests, which can be calculated, these are composite scores such as the APRI, where the components of AST and platelets are taken into consideration. And one more is the FIB-4 score, with where age, AST, ALT, and platelets are taken into consideration. This can be done normally with the normal routine blood test which we do for the LFT and the hemogram itself, and these are very cheap and can be taken as a substitute for the fibrosis or for the cirrhosis. The other thing is a fibro test, where other high-level investigations are needed, such as the haptoglobin, the alpha-2 microglobulin, which are generally not done, and these are specialized tests at designated laboratories only. The other non-invasive test is a fibroscan, which is also called transient elastography. So it needs a dedicated equipment, and the cost is little higher when compared to the prior test. So the non-invasive tests also include the ARFI and the shear wave elastography. This ARFI stands for the acoustic radiation force impulse. This is incorporated, it is a software which is incorporated into the ultrasound itself, and a specified location in the liver can be selected, where without vessels or without any space occupation lesion, the space in the liver can be selected, and further the fibrosis or the shear wave velocity can be estimated in this technique. Also, coming to the transient elastography, in transient elastography, the transducer, it sends a mechanical shear wave, and this is on the screen. It shows the LSM, which is a stiffness measurement, which can be seen, which is on the screen. So this stiffness indicates the fibrosis. There are dedicated cutoff values as reference, which are given with the different etiologies. With the significant fibrosis, the etiology, based on the etiology, the F3 and F4 has to be seen, where F4's dedicated values which have been proposed for the hepatitis B greater than 12 is labeled as a cirrhosis. With the hepatitis C, it's also 12. With patients with NAFLD and NASH, any value, LSM value which is more than 14 is labeled as cirrhosis and can be used for the detection of cirrhosis. What are the advantages and disadvantages of transient elastography? So it's easy, non-invasive, can be done in outpatient community settings. It takes less than 10 minutes to perform, and healthcare staff can be easily trained. However, the limiting factors is a high cost of equipment, and it needs regular maintenance or calibration. There's no universal cutoffs for specific stages of fibrosis. This F3, F4 is labeled, but a borderline of F2 and F3 there's no universal cutoffs. And in very obese persons, it is difficult to measure with transient elastography. So coming to the composite score, which I've been mentioning before, which is the APRI, which is AST to platelet ratio index, where you take the AST level and the upper normal limit of the AST, divide by the platelet count into 100. You also have a calculators online where you can calculate the APRI. The FIB-4 is also utilizing the age, AST, platelet, and ALT with a formula. This cannot be done manually, and we have many calculators. And this FIB-4 calculator can be used to measure the fibrosis. There are also cutoff for significant fibrosis or cirrhosis has been mentioned. For APRI, a low cutoff of 0.5 has been mentioned and a high cutoff of 1.5. A lower cutoff has higher sensitivity, it rules out cirrhosis, and a higher cutoff has higher specificity and rules in cirrhosis. So any value more than 1.5 or more than 1.5 or more than 2 for the APRI, and the FIB-4 more than 3.25 highly suggestive of cirrhosis, and any value which is less than 1.45 in FIB-4 and less than 0.5 in APRI, it shows that the patient does not have cirrhosis. So coming to one case scenario where a 60-year-old male with an HCV infection has a platelets of 88,000 and AST of 58 with upper normal limit of 30. So what is the stage of liver disease? It's a bedside investigation. When you calculate the APRI, it's coming 2.2 with a cutoff index of more than 2 rules in cirrhosis. So the patient can be have a significant fibrosis and further has to be referred to a hepatologist. So there are further other non-invasive tests for assessment of fibrosis and cirrhosis, as mentioned before, and there's also one more test called enhanced liver fibrosis test, and which needs a further specific component. So when to refer to a hepatologist? What is in ideal case of NASH or NAFLD? Early detection is the key. So when you identify the patients at risk with two metabolic factors, type 2 diabetes or steatosis, and you do the history and laboratory examination, you always do for non-invasive testing for these patients with the FIB4 being taken consideration the FIB4 less than 1.3 or more than 2.67. 2.67, the high risk of patient having cirrhosis, hence refer to a hepatologist immediately. However, if it is intermediate risk, you can do a liver stiffness measurement such as the fibroscan, and in a patient having an LSM 8 to 12 or more than 12, it's better to refer the hepatologist because identification of other complications and the immediate treatment is required to prevent the progression into a later stage. So in summary, I'd like to highlight that it is important to assess the presence of significant fibrosis or cirrhosis, especially in patients with HBV, HCV and NASH. It influences the treatment and response to treatment and prognosis. Liver biopsy, although it is gold standard for assessing fibrosis, but has several limitations. So in many simple and easily available non-invasive methods are available and fairly reliable. APRE is the most widely used, easy to calculate and validated. However, FIB4 can also be used in the community settings. So coming to the first slide, which I have mentioned, the diagnosed symptomatic. So undiagnosed patient, which are the priority now with the primary care physicians. However, the ocean which is seen is the non-affected patients where the prevention is better than the cure. So how can you prevent? You avoid alcohol, regular screening for hepatitis B, C, vaccination for hepatitis B, diet and physical exercise, and early detection is the key. So coming to the World Hepatitis Day, so now we are not waiting and everyone has to get tested for hepatitis and to protect you and your family. Thank you.
Thank you very much.